mechanisms of hypoxemia. Let us see the important mechanism. The first is called as ventilation, perfusion, ventilation, perfusion mismatch, also written as VP mismatch, ventilation perfusion mismatch. So this is considered as most common mechanism. Most common mechanism of a hypoxemia is ventilation perfusion mismatch. The other causes, it can be due to a phenomena called as shunt, it can be due to diffusion defect, it can be due to diffusion defect, it can be due to hypoventilation. This diffusion defect and hypoventilation I will discuss in respiratory failure in detail. Shunt we will discuss in the next slide. Now let us see most common mechanism, that is ventilation perfusion mismatch. First of all, what is normally happening? Normally, if this is your alveoli, it will be having certain amount of ventilation, and beneath this there will be blood vessel which will be having certain amount of perfusion. For gaseous exchange to happen properly, generally the ventilation and perfusion will be matching. So if there are two ventilations I have shown in that image, there will be two perfusion. So for gaseous exchange to happen properly, generally ventilation and perfusion will be matching together. Now let us see a disease called as pulmonary embolism. A disease called as pulmonary embolism. Here this will be the ventilation, no big issue with ventilation, whereas coming to the perfusion students, coming to the perfusion, so this is a perfusion here, but there can be a thrombus in the blood vessel. Because of thrombus, perfusion is not happening properly. Now if you see in this image, this ventilation and perfusion is matched, but this ventilation is not having perfusion. So there is a mismatch. So previously two ventilations, two perfusions. So there is ventilation perfusion matching. Now a perfusion is lost because of thrombus. So there is ventilation perfusion mismatch. So when ventilation and perfusion are not matching together, gaseous exchange will not happen. That can result in hypoxemia. So in pulmonary embolism students, in pulmonary embolism, ventilation there will be no defect. Ventilation there will be no defect. There is a perfusion defect. Frequently asked question. Pulmonary embolism is a predominant perfusion defect. Note this point. Pulmonary embolism is a predominant perfusion defect. Now let us see another instance where there can be ventilation perfusion mismatch, especially in COPD emphysema. Now in COPD emphysema, so there will be asymmetric ventilation and perfusion defect. There will be asymmetric defect in both ventilation and perfusion. Asymmetric ventilation and perfusion defects. What is happening in this condition? Because of airway narrowing, airways are extremely narrowed. Because of that, ventilation cannot reach the alveoli properly. Because of airway narrowing, there will be ventilation defect. Because of involvement of capillaries. So we have seen here students, as the disease progress, there will be involvement of alveolar and capillary walls. So once the capillary walls are getting involved, there will be no proper perfusion in COPD emphysema. There will be no proper perfusion in COPD emphysema. And these two defects will not be proportionate. So they will be asymmetric. Because of existence of asymmetric defects both in ventilation and perfusion, there will be ventilation perfusion mismatch responsible for hypoxemia. So point to remember here is, If they ask you pulmonary embolism, there is ventilation perfusion mismatch. Where is the defect? Your answer should be perfusion. In COPD also there is ventilation perfusion mismatch. Where is the defect? Defect is both in ventilation and perfusion. Airway narrowing contributes to ventilation defect. Involvement of capillary walls will contribute to perfusion defect. So this is the most common mechanism. So ventilation perfusion mismatch, as I told you students, is the most common mechanism, Next important mechanism is shunt. Now what do you understand by the term shunt? Shunt means movement. Now for example, there is some excess pressure in the ventricles of your brain. So what you do here, you do a surgery called as ventriculoperitoneal shunt. So through this shunt, so you are trying to make this fluid to move into the peritoneal cavity and decrease the pressure there. So a diversion or movement is a shunt. If there is some portal hypertension, you do portosystemic shunt. You try to facilitate the movement of blood into the systemic circulation and decrease the pressure. So shunt anywhere means some movement or diversion. Shunt with respect to hypoxemia. Shunt with respect to hypoxemia means movement of blood without oxygenation, into systemic circulation. Movement of blood without oxygenation. Shunt is movement of blood without oxygenation into circulation. So this shunt can happen at the level of heart. That phenomena is called as intracardiac shunt. It can happen in the lungs. When it happens in the lung, it is called as intrapulmonary shunt. So there is movement of deoxygenated blood into circulation. This is called as shunt. If it is happening at the level of heart, it is called as intracardiac shunt. If it happens in the lungs, it is called as intrapulmonary shunt. For intracardiac shunt, most important example is a right to left shunt. Let us see what is the normal circulation. Normally from your body, all the deoxygenated blood will go into the right heart. So let this be the right heart. From the right heart, this deoxygenated blood will be carried into the lungs. So this side, generally it will be deoxygenated blood. Now in the lungs, the blood gets oxygenated. Oxygenated blood will go into the left heart. From the left heart, through the systemic aorta, oxygenated blood will reach the body. So on this side, mostly it will be oxygenated blood, and usually there will be no mixing of this deoxygenated blood in your body. Now because of some defect, if there is an opening like this between the right heart and left heart, usually between right heart and left heart there will be a barrier. Now if there is a defect like this, and it is a right to left shunt, now what happens is deoxygenated blood from the right heart will move into the left heart. Deoxygenated blood. Right to left shunt is there is a opening in the heart which is facilitating the blood to move from right to left. So what does right heart contain? It contains deoxygenated blood. When it goes into the left heart, it will mix with the oxygenated blood. So the end result will be mixed blood. Now tell me students, mixed blood, is it good blood or bad blood overall? It is also bad blood, and this mixed blood cannot carry oxygen properly, so there will be hypoxemia. So ultimately this patient will be having less oxygen and he will come to the emergency department with less SpO2. Now what you do, you start oxygen to this patient. Now my question is, will this patient be more responsive to supplemental oxygen or less responsive to supplemental oxygen? So the answer is he will be less responsive to supplemental oxygen. So even if you start oxygen through a face mask or nasal cannula, his SpO2 will not improve much. He will be less responsive to supplemental oxygen. He will be less responsive to supplemental oxygen. So what is the reason? Whatever oxygen you give students, it will go and reach his lungs. So this oxygen given to the lungs is in no way changing this pathophysiology. If you give oxygen to his lung, it is not going to correct that right to left shunt. So always there will be fraction of blood going from the right into the left heart. So even if you give oxygen, it is not going to correct that shunt. So patient will not be that much responsive to oxygen. You give oxygen also, always the deoxygenated blood is mixing with oxygenated blood, resulting in persistence of mixed blood and hypoxemia. So then what is the solution? Treatment here will be correction of that shunt by putting a device or doing some surgery. So ultimate treatment will be closure of this shunt. So if we close that shunt, so blood will not go into the left heart, there will be no mixed blood, there will be no hypoxemia. So ultimate treatment will be correction of the shunt. Even if you give oxygen, there will be no much improvement in the oxygenation, because oxygen will not have any influence on that blood going on to the left side. Coming to intrapulmonary shunt. Intrapulmonary shunt can happen in severe pneumonia, ARDS, acute respiratory distress syndrome, atelectasis. Atelectasis means your alveoli are collapsed. We will take prototype as severe pneumonia to understand intrapulmonary shunt. Before that, let us see normal gaseous exchange. Whatever I write with this color, so this is the normal phenomena, students. So let us see what is normally happening. Normally, oxygen will reach my lungs. It will reach the healthy alveoli, and you can find blood flowing like this. So there will be multiple capillaries. So blood will flow in this direction, and ultimately it merges into systemic circulation. So it merges into pulmonary vein. Pulmonary vein will open into left heart into aorta. Aorta is nothing but systemic circulation. So in a healthy individual, what happens is oxygen will reach from the alveoli into the blood. So because of that, there will be oxygenated blood on this side, and these two will mix, and the end result will be oxygenated blood reaching the systemic circulation. Oxygenation will be normal. So this is the normal phenomena. Now if at all there is a disease, as I told you, for example severe pneumonia. Now in severe pneumonia, the alveoli may be filled with secretions. So whatever I write with this color, it is in severe pneumonia. Now what happens is, this patient will also inhale oxygen. Now this oxygen will definitely go into the healthy alveoli and will reach the blood on the side of healthy alveoli. So this part of the blood will be oxygenated, but this oxygen cannot penetrate these secretions and cannot reach to this side. So this side of the blood will remain deoxygenated, because alveoli are blocked, oxygen cannot reach the blood on that side. Now you can notice the oxygenated blood is coming into circulation, the deoxygenated blood is also coming into circulation. So when oxygenated and deoxygenated blood mix, it will be a mixed blood. Now tell me students, mixed blood, is it good blood or bad blood? It is a bad blood. So patient will have hypoxemia. Patient will have hypoxemia. Now why this phenomena is called as a shunt? Now if you observe here, on the healthy side, oxygenated blood is coming, blood is getting oxygenated and coming into circulation. Whereas on the unhealthy side, so this blood is not oxygenated, but still it is coming into circulation. So there is movement of blood without oxygenation into circulation. There is movement of blood without oxygenation into circulation. And where is this happening? At the level of lung. So there is a shunt. It is happening in the lung. So it is called as intrapulmonary shunt. So you can see this is the fraction. So this fraction of blood is not getting oxygenated, but still it is coming into circulation. So it is called as a shunt. It is called as a shunt. Now this patient is also having hypoxemia. Now if you give him oxygen, what will be his response? So you are giving him oxygen. Will he be more responsive to oxygen or less responsive to oxygen? So this is the supplemental oxygen. I am starting oxygen with a face mask. Will he be less responsive or more responsive? This fellow will also be less responsive to. This fellow will also be less responsive to supplemental oxygen. This fellow will be less responsive to supplemental oxygen. What is the reason behind this, students? Now whatever oxygen I give, it will reach the lung and it will only reach the healthy part. It cannot penetrate the diseased part. So this side it will get oxygen, this side it will get oxygen, it will remain oxygenated blood, it will stay oxygenated blood. Whereas on this side there is no oxygen going into this capillary. So always this blood is deoxygenated. And again there will be mixture of oxygenated blood, deoxygenated blood, resulting in persistence of mixed blood and hypoxemia. Now whatever excess oxygen you give, it will reach to this side of the alveoli. It will reach to this side of the alveoli. And one point that you need to know is, hemoglobin has a property called as saturation. Beyond a point, whatever excess oxygen you give, it will not accept, because SpO2 maximum will only be 100%. It will not be 200%. Simple example. If a patient's capacity is to eat one Hyderabadi biryani, if you feed him 2 Hyderabadi biryanis, he will not eat because his capacity is only 1. He will be saturated after that. So it means even if you give excess oxygen, it will only go to this side. And hemoglobin, after a point, it will not take extra oxygen. So this part will remain oxygenated, whereas this part is always deoxygenated. So again, oxygenated and deoxygenated blood will mix in circulation, resulting in hypoxemia. Then what is the solution? So this is a lung disease. Even if you are giving oxygen, patient is not improving. Then what to do? See, definitely you should start treating the underlying disease. If it is a pneumonia, give antibiotics. So for antibiotics to function and the secretions to clear, it will take 2 to 3 days. So meanwhile, how to maintain patient's oxygen? For this, the solution is putting an endotracheal tube and ventilating with positive pressure. Invasive mechanical ventilation is the solution. So what is the principle behind this? You put a tube into the trachea and you are pushing oxygen with positive pressure. Suppose I am sitting in this room. I need to move out from this room through a door. Now if multiple people are standing there, still how can I go out through that door? I will push them aside and I will make my way out. In the same way, once you give positive pressure into the alveoli, whichever alveoli have been closed up to now, they will open. Oxygen will go from the alveoli into circulation. Now if the alveoli are filled with secretions, so this positive pressure can push the secretions aside and facilitate oxygen entry into circulation. So this invasive mechanical ventilation will cause better transfer of gases. You can see in the image there was alveoli filled with secretions. So alveoli filled with secretions. After giving positive pressure, it can push the secretions aside and facilitate oxygen entry into circulation. So point to remember here is, let it be intracardiac shunt or intrapulmonary shunt, the common feature, both will be less responsive to supplemental oxygen. So the pathophysiology and treatment is different. So common feature is, let it be intrapulmonary shunt or intracardiac shunt, both will be less responsive to supplemental oxygen. So these are regarding the important mechanisms of hypoxemia.